Well, hello everybody and welcome back to the podcast. My name is James Waldron, GPnotebook podcaster, and it's really great that you can join us today. I'm really happy to say that we are introducing a bit of this new part of the series focusing on HIV as a really, really important topic that we should be aware about in primary care, and certainly something we could be doing better. I have two guests joining me today. I have Dr Grace Bottoni, GP in Lewisham and HIV and Hepatitis C champion, as well as a special guest today, Dr Mel Rosenvinge, who is a consultant HIV specialist in Lewisham as well. Welcome, guys.
Thank you. Thanks, James. Thanks so much for having us.
Thank you for having us, James.
Oh, well, I'm really glad that we've been able to get you here to share your experience and your knowledge about this topic. First of all, Grace, you've helped me set these up, and we met when you were talking about hepatitis C and like, and you're also the HIV champion. Can you tell me a little bit more about your role and why it's so important for primary care?
Yes, James. So, as you said, my name's Grace, and I'm a GP in Lewisham, and I've been an HIV champion now for a few years. I'm employed by the Lewisham Council and also more recently by the Fast Track Cities London initiative. And really, my role is to raise awareness about HIV, particularly in primary care, focusing on reducing the stigma amongst healthcare professionals and healthcare teams, and increase testing really in primary care. So I'm hoping to be able to give the GPs listening a bit more confidence surrounding HIV.
And it's a wonderful mission to have, because I think increased confidence and understanding about this is so important for everybody involved. You managed to link us with Mel today, and so glad to have you today, Mel. Would you like to introduce yourself?
Yes, of course. My name's Mel Rosenvinge. I'm a consultant. I work at Lewisham in Greenwich Hospital. I've trained in various hospitals around London and have specialised particularly in HIV medicine. I'm very pleased to be on this podcast.
Well, we're so glad to have you. So much expertise in the room. Well, so I think without further ado, let's really get into it. And it's going to sound like a really straightforward question, but I think it's important to start at the beginning. What is HIV? Let's just have a reflection on what we mean by HIV.
So HIV stands for the human immunodeficiency virus, which is a bit of a mouthful, which is why pretty much everyone says HIV. So going back to basics, this is what I tell my patients who've been diagnosed with HIV. It's basically a virus which infects the immune system. It infects a type of white blood cell called a CD4 cells, which I always liken to being a bit like the generals of an army that help your body fight off infections. You can get sick from the HIV virus itself, like when you first get the infection, you might be really ill with like a flu-like illness. You can also get sick because your immune system is no longer able to fight off infections or repair itself against damage that causes cancers and things like that. It's a very fascinating virus and quite complex.
And it sounds like it impacts on lots of different symptoms. You mentioned there about cancers and general other processes. Does it impact on, I suppose, our health overall? Because I know it's got some relation to cardiovascular disease and the like.
So HIV is multisystemic, and it sort of presents itself quite differently in each individual. I think when we come to understand a bit more about our own genetic makeup, we'll understand that a bit more. So yes, people can get unwell from this sort of more special HIV related things, but also just because if you've got that ongoing inflammation in your body, then you may be more likely to have things like a heart attack, which I think is underestimated actually. So just getting somebody on treatment reduces their all-cause mortality from HIV and from related conditions.
And I think this is a really important place where GPs can be advocates and help update people. Grace, what can we as general practitioners do to help people understand that sort of broader context of HIV?
Well, yeah, that's a really good question, James, because I think what historically, I guess, people think that HIV is a condition that is managed in secondary care and GPs don't get involved at all. But as Mel said, this is a multi-system condition, and many of the conditions that do develop, like cardiovascular disease, are managed in primary care. So GPs are probably more likely to get more involved as people living with HIV are living longer and healthier lives. They might develop chronic conditions that are managed in primary care. So it's not something that we can ignore.
Yeah, well, brilliant. And I think that shows just how important it is for us to update ourselves about it. One of the things that we can also do is, I suppose, help educate people about what HIV is and about, I suppose, how it's transmitted. We talk a lot about transmission here, but what do we actually mean by transmission and how is it transmitted?
So HIV is passed from one person to another through contact with certain bodily fluids. We mainly think about sex for this. So particularly if somebody was to have unprotected sex without a condom, then they may get HIV also through sharing of injecting equipment, which actually is less of an issue in the UK because we have very good needle exchanges. You can also pass it from mother to child, usually at the time of delivery if someone's not on treatment, or through breast milk if somebody's not on treatment. And I'm mentioning about not taking medications because actually, if somebody is taking HIV medicines and their virus is very well controlled and they're not missing any tablets, then then you can have sex without a condom and know that you're not going to pass it on to someone else. So someone is basically not infectious at that point. So we call it U equals U, undetectable is untransmittable.
Um, are there any considerations for likelihood of transmission through those different routes that you mentioned?
I mean, the important thing about the U equals U message is that it is just incredibly reassuring to people. So, just to clarify, in case I didn't explain it very well, but when we say that someone is undetectable, what we mean, their virus is still there in their blood. So, if they were to stop their medication, the virus would come back, but that the virus has basically got it under control. And we talk about a level of less than 50 copies per mil as being undetectable. And we really want to spread this good news message to everybody that if somebody's taking their medicines properly and their virus is undetectable, then they're not going to pass it on to someone, even if they have sex without a condom. Also from mother to child during birth as well, which is just a wonderful thing because then we can reassure families that they can have children without worrying about infecting their children, which I think is important. I've also had patients who've been reassured who actually aren't sexually active anymore, and who I had a grandmother who said to me, "Oh, I can sleep in the same bed as my daughter now." And I was like, "But you could always sleep in the same bed as your daughter because HIV." Is quite difficult to get actually. It's through sort of sexual bodily fluids and mucosal surfaces. You can share drinks with people, that's not a problem. And I think even for people who aren't sexually active, it's a really lovely reassuring feeling that they can go about life as normal. And we really hope that it will reduce stigma because actually HIV is not easy to transmit and it's quite easy to prevent transmission. And therefore, things like sharing cups and glasses and things like that is of no problem at all.
Absolutely. And toilet seats as well. Because I think I've had a lot of patients who are worried because they went to a public toilet and they're worried that they might have acquired HIV. I don't know where this information came from that HIV can be transmitted through urine, but it's not the case.
But I mean, there's lots of mis and disinformation out there, and a lot of deeply held worries from people. And so I think getting the information from really good sources, and their GPs often being one of those sources, is so important.
Exactly, and there's also the misconception of who might be living with HIV or who we should be testing for HIV. I think because historically, it was seen as a gay disease back in the 80s, and we know that that's not the case anymore. It's anyone could be living with HIV or be diagnosed with HIV, and that's why we should be offering a test to anybody who asks for one, but also we should be offering it to anyone, especially in areas of high prevalence. And if you're not sure if you're living in an area of high prevalence of HIV, you can just go on the NICE CKS guide, but it's got a link to the UKHSA data, and you can look at your area to see if you're living in a high prevalence area.
I mean, my take home about HIV testing is if you think about it, you should do it. It's an incredibly cheap test. When I was training, we used to talk about testing people for glandular fever, and that was a far more expensive test that arguably didn't do very much with the result. There are certain indicator conditions where we think more about testing for HIV. These are important to think of, that we are also now rolled out HIV testing in accident emergency departments in high prevalence areas, so throughout London, to pick people up, because HIV can affect anybody. And most of the late diagnoses that we have, so they're diagnosed when their immune systems are very low and they have a low CD4 count. There have been multiple opportunities before to test them earlier. They've had multiple contacts with health professionals, and particularly if you don't fit the health professionals' kind of idea of who might have HIV, you can be quite delayed in getting an HIV test. And certainly when we first rolled out HIV testing in Lewisham A&E, we had wondered about having an upper age limit of the people that we tested, and the first person that we diagnosed was 85 years old. And that pattern carried on, actually, with 20% of our diagnoses being in much older adults who it hadn't been considered as a diagnosis from other people. So it was incredibly useful to test those people.
Yeah. Well, and like you said, Mel, it's about missed opportunity sometimes in primary care. I remember doing an audit locally, and the people with the late diagnoses, some of the things that they presented in general practice were things that we saw quite often. So, for example, seborrheic dermatitis, very severe psoriasis, unexplained weight loss, unexplained lymphadenopathy. What was the other one? I think it was recurrent thrush as well. And you should read, and chronic diarrhea. That's the other one that is seen quite often. And also anyone who has an STI, who's been diagnosed with an STI, don't forget to also offer a blood test for HIV and syphilis if they've had positive chlamydia or gonorrhea. And also with anyone who's had an abnormal smear, that's who we should be offering an HIV test to.
I think it's good for us to understand, sort of, I suppose, that to broaden our thoughts as to who we might be testing for HIV, and to make it a bit more part of the normal conversation that we have, and I suppose reducing some of our internal bias and stigma to that. You know, actually, this isn't a big deal. It's just something we test everybody for because of the prevalence locally. Do you think that's a good approach?
Definitely. I mean, we need to normalise HIV testing. We've always exceptionalised it. So, I mean, there are some things that were different in the past. So many, many years ago, if you offered somebody an HIV test, even if it was negative, that would count against them in insurance claims and profiles, putting that together. Actually, now a lot of insurance companies ask somebody to have an HIV test before they offer insurance, and they do offer insurance to people who have HIV as long as they're well controlled and on treatment. And I would argue that HIV has such a good prognosis and outlook with very simple medications to take, that actually it requires less counselling really to talk about it than a lot of the other tests that we do. You know, if you were going to diagnose somebody with end-stage renal failure, for example, I think that would have much more of an impact on that person's life than HIV, certainly from a sort of medical perspective anyway. And we just want people to do the test. So we almost want people to deal with if it's going to be positive later. So when you talk to somebody about doing an HIV test, just say, I'm going to do an HIV test. We're trying to do it in more people. It's, you know, a good thing to do. Or I mean, in A&E departments, and we don't even necessarily say it anymore as long as it's up on the posters around for people to see. We do have to reduce people's concern around offering it. You are not passing judgment on the person in front of you. You are offering them good care.
Absolutely. I completely agree. I think a lot of the GPs or healthcare professionals in primary care do worry that their patients might get upset if they're offered an HIV test, so they might get angry. But even, the worst thing they could say is, no, I don't want a test, and that's fine. But you've started that conversation, and it might be sort of, I guess, an educational moment, because you could say, well, that's fine. You don't want one. That's not a problem. But we just have to offer it to you. And just so you know, HIV is no longer a death sentence, and there is treatment available. And if people are on the correct treatment, they can't pass it on.
I love being able to tell people that it really shouldn't affect their life in terms of certainly younger people. So I'm like, you can be a pilot now. All you need to do is take your medicines regularly. You can be a midwife, you can be a surgeon. You just need to take your medicines regularly. There is nothing that you can't do, basically. And so when we do see people who are HIV positive, we don't use old terminology like AIDS, which we tend to shy away from because there's huge stigma attached to that. We talk about HIV or advanced HIV if their immune system is quite low. And it was very positive because actually there is so much that we can do, and we can keep people healthier. And arguably, for some people, they get more input from medical services. I mean, I worked overseas for a year, and I certainly saw that the people who were in the HIV clinic had better treatment of their diabetes and their blood pressure and that sort of thing than those who didn't, which was an interesting outcome. And I think it's very important that we help people with HIV, because often they come from very poor communities, lots of social deprivation, housing, immigration issues, stigma, maybe even sort of things like domestic violence and that sort of thing. And as clinicians looking after them, we can help them navigate the system, and we can help them to have healthier lives.
And I think destigmatizing this as a condition, and the screening of it particularly, which feels like, a thing that we should be able to do quite easily, feels like a great goal to have for primary care, and that interaction between primary and secondary care. And I think it's also quite nice to think that because they are getting frequent engagement with healthcare, that they've got improve outcomes in other respects. It's good to hear that the diabetes can be better controlled, but of course we've got to remember the multi-system aspect of this. And you mentioned earlier a little bit about premature aging and that being a challenge for people, and of course that just makes everything much more complicated.
Yeah, we've definitely noticed that. So, I mean, we're learning all the time. When HIV first became a phenomenon that we were aware of in 1980s, obviously at that time there was no treatment for it, and people were put on palliative care pathways, and unfortunately didn't make it. And now we got better drugs against HIV, but they could still cause some toxicities to your body. And we were able to treat HIV, and people were surviving. Now we have developed even better drugs, and there are actually also even injections to treat HIV, and people don't have the same toxicities from the medications. But we are noticing that perhaps people living with HIV, especially those who were diagnosed late with very low immune systems, they probably are aging a bit more prematurely. They do seem to be at increased risk of certain cancers, for example, lung cancer. And we really need to be trying to help them diagnose these comorbidities earlier and manage them appropriately so that they can live good and productive lives.
But really, what saddens me is just that the people who are diagnosed late are people who tend to be affected by health inequalities anyway in the UK, because we know that people who are the people who are more likely to be diagnosed late, and by that we mean with a CD4 count, is it less than 200 ml?
So
is that right?
we talk about late, it's a bit historic actually. We used to not give treatment to everybody. So we used to wait for someone's immune system to drop below a level of 350 before we started them on treatment. That stopped in a sort of landmark study back almost 10 years ago now, where they randomized people to follow that and start treatment when their CD4 counts were less than 350. and others just to start immediately. And they found that they had to stop the study early because there was a reduction in all-cause mortality in those who were on treatment straight away. And that was like a reduction in heart attacks, a reduction in people having terrible thrombocytopenia. So lots of not sort of traditionally necessarily thought of to be HIV-related issues. So we call those who are late, those with a CD4 count less than 350. But there, as you mentioned, when your CD4 count's less than 200, that is a very late diagnosis. And at that point, you are much more likely to get the sort of weird and wonderful infections that we associate with HIV. So the fungal meningitis called cryptococcal meningitis, for example, tends to happen to people whose CD4 count's less than 100. And often when people get to that level, they can have multiple diagnoses like this all at the same time. And their chance of becoming very unwell and sadly dying is much higher if they are diagnosed late. So we're really trying to get people diagnosed early. And also because if somebody knows that they have HIV, they immediately change their sexual behavior. And if they're on treatment and effective treatment, then they won't be able to pass it on to others. So it's not only helping the individual, it also prevents onward transmission, which is incredibly important.
And I mean, I think that's a wonderful point that we've ended at here, that by the only way we can really help people and help people earlier, and we know that the outcomes are so much better if we get that earlier, is by screening and by thinking about it and by incorporating it to our day-to-day practice, being good at asking about it, screening. You mentioned checking in A&Es. I'm not sure if is that around the country or is that just in
It
London?
is around,
Yeah.
it's definitely around England. More than 100 emergency departments around England are now doing opt-out testing, and more to come, I think.
Yeah, so NHS England have been rolling it out. It's been such a successful project. So they've been rolling it out in areas of higher prevalence of HIV. So it does depend on what the local sort of rate of HIV is. What I would say though is even when the sort of pickup rates drop, it will still be so useful to do that, because if we actually want to get to the the WHO and the UK intention of us having zero HIV transmissions by 2030, we're going to have to work harder at finding those cases. Because if somebody knows they have HIV, then we are going to prevent them giving it to somebody else. And that's where I worry a little bit about things like the funding of international HIV projects. And if that is reduced, as we've heard in the news just recently, that may mean that that more people go without treatment, and then when they become viremic, they may be more likely to pass it on to others. And we cannot treat HIV in isolation as the UK. We know this from the COVID pandemic, is that we're all linked. So it does need an international approach.
Yeah. Brilliant. And advocates, such as Grace, such as yourself, such as hopefully everybody that's been listening to the podcast today is going to become an advocate for more testing, opening up those conversations and really taking that message out there. And wouldn't it be great if we could take this across the UK and in fact to the rest of the world, to encourage that collaboration and free medication and.
Well, the UK are complete leaders in this, actually. What we've done in terms of managing people with HIV since the beginning of the pandemic is fantastic in terms of getting people diagnosed and on treatment. We should, give ourselves a bit of a pat on the back for doing quite well with that. Although I do worry that sometimes some of our publicity campaigns and things like that in the past, unfortunately, did increase stigma quite a lot. And I would really like that to be something that we looked at going forward, is that, people with HIV on treatment, they're not going to pass it to anyone else. Please, we should stop making assumptions about how they got it and people's lifestyle choices, because it really can affect anyone.
So we've talked about a lot today. We've talked about transmission. We've talked about screening and really the importance of picking things up. And I'm glad to say that we've got a second part of this this first opening bit of our HIV podcast series on treatment and about what actually happens after that, that we detect it in primary care. So I'm really looking forward to that. And then also we're going to be doing another one a little bit later on stigma and language and trying to understand the impact on the patient. So we're really covering all of the bases here. And finally, another one on PrEP and helping to prevent that as well. So we've got an awful lot of things to cover, and I'm really, really looking forward to those future conversations and bringing this education to people across the country. So for today, thank you very much, Grace.
Thank you. Thanks for having me.
And thank you so much, Mel.
Thank you. Thank you for having me.
And we'll speak to you again very, very soon. And to you listening at home, thank you for listening, and we'll see you at the next podcast. Thanks.